ejaculates.
Was he ejaculating earlier?
No, sir, not ever. No, sir.
So you can perhaps change that to say absence of ejaculation.
Okay.
Okay?
Okay, sir.
Yeah. Priyanku, now it's your case. You take over.
Yes, sir.
So you can tell him when to move, when to stop, ask your questions.
Yeah. Can we move to the history of present illness?
What are the questions you want him to ask?
Shall I proceed, sir?
Yes, sir. Yes.
Patient apparently all right 7 years back when he noticed a gradual.
1 second. Hang on. Priyanku, Dr. Manish asked you something.
Yes. Yes.
You want to know what are the questions you would like him to ask. Please answer that.
Yes, sir. So from the chief complaint, sir, was there only regarding the voiding complaint, was it only related to delay of initiation or any other complaints related to voiding?
Pardon, please.
Okay, so you will ask a complete history about the voiding symptoms.
Yes.
What else will you ask?
Okay. Sir, I'm just going on the history of present illness, sir.
Wait.
Please move closer to the mic, Priyanku.
Yes, sir.
And Shubham,
Yes,
wait
sir.
until the question is answered and then you can go back to your presentation.
Okay, sir.
Dr. Manish has asked some questions. Let him answer all those. Yeah, Priyanku, go on.
Yes, sir. So the main chief complaint is delay in initiation of voiding here, sir. So
we agreed to that, Priyanku. You will complete the voiding history.
Okay, sir.
There is a very unusual, strange history here.
Yes.
He does not ejaculate. So what else would you like to know?
Whether he is having the normal features of developing an orgasm or having the sexual desire or not, or whether it is only problem related to ejaculation.
No, he is having normal sexual desire with normal.
Wait, Shubham, wait. Let Dr. Manish finish with his questions, then you can go ahead. We only want to know what are the questions that Priyanku has got in mind. The answers to those questions you can give later.
Okay.
Yes.
So an ejaculation by itself is a disease, and you will need to read up on the full management of an ejaculation. How to classify it, what are the causes. In this patient, at this stage, like Shubham said, you will want erection, you will want libido, and you will want whether it is orgasmic or without an orgasm, there is an ejaculation. If there is retrograde ejaculation, is there a typical history you could ask for?
Whether he is passing seminal fluid or contents in urine post an attempted ejaculation.
Okay, go ahead.
So, patient apparently all right 7 years back when he noticed a gradual appearance of hesitancy by passing urine. There was a gradual increase in duration of hesitancy, and the hesitancy was associated with straining. Initially used to void completely with strain, but since 2 years, there is complaint of incomplete evacuation with increased frequency and urgency. There is also associated narrow stream of urine and associated with sensation of incomplete emptying.
Manish, go on. You can ask them.
Priyanku has to ask, sir. So you take it forward. Now, what other symptoms has he missed? What symptoms of the lower tract do you want?
Yes, he has mentioned hesitancy and straining.
Do not repeat.
Is there any history of intermittency?
No, there is no history of intermittency.
Priyanku, once he says straining and voiding incompletely, it doesn't matter whether there is intermittency or not. It doesn't add value. You should ask questions which add value. This will help you get to the bottom of the case.
Yes, sir.
These questions, first of all, will be related to voiding. Next will be related to his unejaculation or absence of ejaculation. The third will be related to other conditions which might have a bearing on his symptoms. So begin with his voiding symptoms.
So Priyanka, we are in agreement that he has voiding symptoms.
Yes,
He
sir.
also mentioned storage symptoms. Would you like to probe that further?
Yeah, he said that there is increased frequency of maturation. So I would like to know what is the daytime frequency or whether there is any presence of nocturia.
Okay, daytime frequency, nocturia, what else? In the storage symptoms. What is the first thing you ask when somebody comes to you with frequency and urgency?
Is the increased frequency associated with increased water or fluid intake,
So
sir?
you want to know his water intake and
Or fluid intake, sir, and frequency of intake.
that is the input. About the output, what do you want to know?
Is it tallying with the amount of intake, sir? With the amount of output, daily output over total output per day?
Supposing it is not tallying, so what? Can you word it better? The question you want to ask. Can you word it better? Whenever we have people with frequency, we want to know how much they void each time.
Yeah, yes, sir.
Correct? So we
Yes,
look
sir.
at intake on the intake side and we look at urine output
Yes.
on the output side. We may measure all this later, but when we take a history, the patient will tell you recently, his symptoms are recent. He said, now I'm passing a lot more urine than I used to pass.
Yes, sir.
So Priyanka, this is the most basic form of history taking in urology, the lower tract symptoms. So I would suggest write down storage symptoms, write down all the voiding symptoms, write down the associated questions in one order. Try it out once at home, because if you get a case, these are the questions that you're expected to ask. And this is almost mathematical. You don't have to think too much. If you get a case of BPH, these will be the questions that you need to answer.
Okay, sir.
Okay. Shubham, you
I'll
can
note it up, sir.
There is history of pain while voiding since 2 years. The pain occurs mostly at the back while voiding, mild in intensity, dull aching in nature, radiating from back to the suprapubic region. Pain is aggravated with voiding, defecation, and attempting masturbation, and it is relieved after voiding and taking rest.
So what more about the pain would you like to know, Priyanku? You said some pain. Does it satisfy you? Do you want to zoom in further on the pain to get to understand it? Shubham,
he said that pain aggravated with pain aggravates with voiding, defecation, and attempting masturbation. So he had described that pain occurs mostly at the back while voiding. So during defecation and attempting masturbation, is it the same kind of pain?
Yeah, no, while
Does it
voiding,
appear the same?
Even more basic than that. Even more basic. You read the description there and see what you would like to ask. See, sometimes we also mix up our history. The patient might not understand our terminology. So we must slowly elicit this in his own language. What about the pain do you want to ask him? Any pain which a patient relates to a certain natural act, like voiding or defecation or whatever, you will want to know whether it is only at that time or whether it is present even at other times. Correct? Yes or no?
Okay, sir.
Priyanku?
Yes, sir.
It doesn't matter. Don't be scared here. You
Yes,
take
sir.
the wrong answer.
Yeah,
We
it is
take the
a-
right answer. Don't worry. Okay.
Yeah.
So the
Yeah,
patient
yes, sir.
might say, I have pain only while passing urine, because the rest of the time it might not matter to him. So you want to know whether he has got pain. Now it says something about this pain radiating from back to the suprapubic region. What is this? Is it any
I
particular?
would like to know which position.
No, any pain.
I would like to know.
It begins. No, hang on for a minute, Priyanku. Any pain which begins in the back
Yes.
and radiates to the suprapubic region, what could be the etiology of that pain? Most likely etiology.
Stone disease, sir. Stone
Okay,
in the ureter.
Come on.
Or
Come on.
in it can mimic a pain that radiates from the flank loin to the groin, sir. So
He hasn't said loin. He says this
yes,
is
yes,
back to the
back.
front. Let us take this as seat belt type pain. Just goes around the suprapubic region and back at the same level. Can you think of any etiology which will produce pain confined to a certain geographic region or distribution? What is the characteristic of radicular pain?
Shooting type of pain.
See, more than shooting, radicular pain occurs in the area of innervation. Right? And
Yes.
typically, this is seen in lumbar vertebrae and sometimes in the thoracic vertebrae. And it gives rise to what used to be called waist belt type, seat belt type, and other types of pain. This would be a waist belt type of pain because it's in the suprapubic region. Now, if we assume, we might be wrong, that this is radicular pain he's referring to, why does he get it only when defecating or micturating? Why not at other times?
So while defecating or micturating, sir, there is often associated straining, sir.
Sorry?
So straining is present, sir.
Okay.
Due to the straining, the lower abdominal muscles they work to strain, sir. And if there is any dermatomal supply arising from any pathology in the back, so it can lead to
Why should it cause
that kind of pain, sir. Mainly, almost.
Abdominal muscles are in front, he's straining. Why should it be pathology in the back? Your answer is right, but your reasoning is wrong.
Sir.
So you should get that reasoning right. Why does straining
Yes,
cause this type of waist belt kind of pain? It is very typical of the condition. Dr. Manish, would you like to paraphrase this some way? Maybe he can understand better.
I just ask him to strain and see what happens to his back muscles. No, No, you can see that, you can feel it for yourself and then you will be able to figure out.
You can do that now. You could strain and see what happens to your back.
Yes, sir.
Don't do it if you have a full bladder.
And then if you have to do it for 2 years, maybe 3 times a day or whatever, whenever you're voiding, you're defecating, you're masturbating, a lot of toll on the pelvis.
It happens because when they strain, the alignment to the vertebrae changes, the lumbar lordosis changes, and the alignment to the pelvis changes. So if there is any compressive lesion on the nerve roots, that gets aggravated because
Yes.
the neural foramina get narrowed.
Yes.
You get it? That's why even people with slip discs will tell
Yes,
you,
sir.
I'm okay, but if I strain, I get my pain.
Yes.
So we should be able to ask the right questions and correlate this. Let us assume that that is what is happening. What other questions would you like to ask which might have a bearing on the cause of pain? Not about the pain itself. Questions which might have a bearing on the cause of pain. Or you want to wait for some more time for them to give you the next slide and then ask?
Yes, sir. Is there any other associated histories I would like to know, sir?
Any other associated history can be, or what is that moon that came day before yesterday? White moon.
Be specific, man. Be specific.
Whether there was any history of trauma in the childhood?
If there was trauma, that would have been there right in the presenting complaint. That all this started following trauma. Even if there was trauma, what should cause this kind of pain? And what associated symptoms might be present? Signs and symptoms. Okay, we'll come back to this. Let's move on. Yeah, we've covered this many times in the past. Let's move on. Doesn't matter. We'll come back. Dr. Ganesh has a good memory. Please remember that he's not going to let you go.
There is a history of an ejaculation since puberty. Patient tried masturbation several episodes but associated with pain. Pain is moderate to severe in intensity in the perineal region while attempting masturbation, forcing him to stop the procedure. There is associated nausea and vomiting. Patient is able to achieve normal erection of penis, orgasm, and normal sexual desire.
You see now, the pain that he has during masturbation is different from the pain he has while defecating or urinating. Right? So we are dealing with two different types of pain or two different origins of pain. And this is associated with nausea and vomiting. So what does this mean?
You can know when some patients have urinary colic, they get nausea and vomiting. It's got nothing to do with the GI tract as such, but it is reflex, pain.
Reflex.
Yeah, reflex. The pain is so intense that you're sick, you vomit.
Yes, reflex pyloric spasms.
So this pain is pretty severe.
Yes.
And in his desire to ejaculate, can you imagine? Just picture this guy trying to masturbate. He has never had an ejaculation, and he's trying like hell. So he must be doing very vigorously, trying to prove that he is a champion. Nothing is happening there. But at the same time, He gets orgasm. He gets orgasm.
Yes. So is there any history of nocturnal emissions, sir? I'd like to know about it. Since by voluntarily he is unable to ejaculate while masturbation.
No, the two are very different, Shubham. Okay, having nocturnal emissions is different from having an ejaculation. Again, like Dr. Manish said right in the beginning, maybe you have to go back and read these mechanisms well. Okay?
Yes.
There can be nocturnal ejaculation, there can be nocturnal emission.
Emissions.
Both are different. But why does he have, Priyanko, why does he have pain in the perineum? His old pain was in the back, now it's in the perineum. What suspicion does it give rise to in your mind?
Sir, some kind of obstruction at the opening of the ejaculatory duct, sir. That is causing normal orgasm but absence of ejaculation, sir.
Obstruction in the ejaculatory duct, if it causes pain, where is the pain? Usually, when there is an obstruction to a duct or a tubular structure, then the pain is upstream, right? So, what is upstream of the ejaculatory duct openings?
So, towards the seminal vesicles.
Yeah, and
Vast difference, sir.
right, vas deferens and the epididymis, right?
Epididymis, yes.
Okay, let's come back to this later. Let's move on.
Coming to a negative history, there is no history of similar complaints in childhood, no history of fever with chills with associated dysuria.
Shubham,
Yes,
just 1 second. Do you think you would have ejaculated in childhood?
no, sir, I am combining the three.
No, don't do that. Okay. For your own presentations in the exam in future, don't do that. You can say no history of urinary complaints in the childhood.
Okay. There is no history of fever with chills with associated dysuria, no history of pulmonary discharge, no history of sexual contact. There is no history of any pelvic surgery, no history of diabetes mellitus, polio, tabes dorsalis, or any spine injury.
At 19 years, you expect tabes dorsalis?
No, sir.
When you put all these negatives, let there be some sense in it, but you can't. This is a whole note of everything in the whole book. What is relevant to the issue at hand, you put what is there.
So there is no history of urethral or meatal itching or irritation in between the voids, and no history of hematuria. There is no history of tuberculosis, any swelling elsewhere in body, or any discharging sinuses, or any history of radiotherapy. No history of nocturnal emission. There is no history of discoloration of urine post failed attempting ejaculation. No history of any inguinal scrotal swelling with persistent discharge or sinus formation. No history of any urogenital swelling in childhood. No history of trauma to spine, genital or perineal lesion. No history of any medication for stress or anxiety or depression. And there is no
By the time you finish this, he would be utterly confused if he has not gone off to sleep.
Shubham, can I suggest, when you have to give even a negative history, a
Yes.
much better way to classify it is saying, okay, I'm covering first the lower tract symptoms. So I would say burning and hematuria I would exclude.
Yes.
Then I would cover all the sexual symptoms or all the andrology symptoms.
Yes.
Then I would go on to possible etiologies which explain all this.
Okay.
Okay, so anything, if it's a malignancy, there are relevant questions to be asked, but learn to classify your history. As you present, your examiner will know that, okay, he has thought of this, and then you will not have a lot of questions coming to you unnecessarily.
Okay.
So that's what you have to do. And this is a textbook of PowerPoint presentation. You cannot have so many lines in one slide in a PPT.
Okay.
Carry on.
One symptom that's been left out earlier and now is incontinence. See, he's got frequency, he's got urgency. You've not told us whether he's got incontinence.
There is no incontinence.
So that has to come there. Okay? Negative incontinence means something. Incontinence present could mean something else.
Yes.
So wherever you say urgency, frequency, incontinence must accompany that complex.
Okay.
I think the only thing left to add in today's world is no history of vaccination. You know what corona will produce, no? Vaccine or no vaccine? New symptoms.
By next year, we'll know.
Yeah.
The past medical surgical history. In 2017, patient had a complaint of right inguinal swelling, for which he consulted one hospital, and where he undergone ultrasound abdomen pelvis.
Acha, Shubham,
Yes, sir.
here again, you can simply say had inguinal swelling and underwent orchiectomy or whatever else.
Okay.
No need to say underwent ultrasound and then underwent blood test and underwent anesthesia fitness. All that's not required.
Okay.
What do you think that swelling was?
He was diagnosed with undescended testis.
So that would have been an orchiectomy. Could it have been anything else?
Hernia, sir.
It would have been a hernia, right? So it is an inguinal surgery, query undescended testis, query hernia, query a combination of the two.
Okay.
Right.
And in your last slide, you had said no inguinal swelling. So it's a little confusing.
Sir,
Discharge, but
I said in the childhood period, sir, it was happened in the.
so make sure your history is not confusing. That's all.
Okay. In April 2019, the patient obstructive voiding symptom continued, for which he again consulted hospitals, and there he was diagnosed with prostatic cyst. Patient underwent transurethral deroofing of the prostatic cyst, and the cystic fluid was sent for fluid analysis. Post deroofing, patient voiding symptoms slowly progressed again and was later referred to this hospital.
Priyanku, what do you think has been going on? Supposing you were the urologist or I was the urologist, what do you think is going on with the management?
Sir, he has been having these symptoms for some time, and so
Not
already.
the symptoms.
Yeah.
Looking at this slide, he had some inguinal surgery and had a testis removed.
He underwent orchidopex. Yes.
Then he had something else for which something else was done. Right? And after the second surgery, his symptoms worsened. So, is there something that is incongruous, something we should have thought of instead of having surgery 2 times? Any further investigations that ought to have been done before the orchiectomy? Patient has come to you.
Yes. Sir, evaluation for undescended testis.
Okay.
Any congenital syndromes?
Not any. You have to specifically say what are the congenital genitourinary tract associations of undescended testis. What other anomalies could be there? lesson to everybody who's listening and all the residents. See, when somebody comes at 19 years with something like this, I think we have to make a comprehensive evaluation of everything that could be wrong. We can't treat it piecemeal in this fashion. Very important if the person comes at a younger age. But even at 19, as a young adult or adolescent, we have to evaluate completely and then put a knife to the inguinal region.
Shivam, I'll give you a hint. In embryological anomalies of the testes, especially undetected testes, where did the testis arise from? Where is the testis first?
Priyanku.
Yes.
Where is the testis from? Sorry, Priyanku, he is the one. Well, what do you mean? You don't know? Where is the testis?
Yes, so yeah, it can be in the inguinal canal, sir.
No.
Where does it start from?
First gonadal tissue in the embryo, where
Yes.
is it located?
In the lumbar regions.
Lumbar region. No. Where lumbar? Any specific? See, you have the testis, you have the gonadal ridge.
Yes.
Right? The gonadal ridge is very close to the pronephros. That's how the kidney develops.
Yes, sir.
Okay? Because from the coelomic epithelium, these cells migrate. Alright?
Yes, sir. Yes,
And
sir.
you get the nephrogenic cord, you get the testis cords. Now these two are all very close to each other. So therefore, if there's any congenital anomaly in the testicular development, it will reflect just by virtue of its close proximity in renal. So when somebody asks you a question as to if somebody has got a problem with undescended testes, there must be, you should look for immediately something else with the kidney. Is the kidney normal on that side? Is there a kidney on that side? Is there a pelvic kidney on that side? These things will happen. It's,
Yes.
it's a then the testis comes down, isn't it? It's not stuck there.
No, yes.
As it comes down, it then meets with structures in the Wolffian duct, isn't it? That's how the spermatic cord, that's how the vas deferens comes inside.
Yes.
So these are two different situations. And therefore, when that happens, there's likely to be an anomaly related to Wolffian development.
Wolffian.
And if the testis cords do not actually separate into male or female, when that descends down, you will get Mullerian. So you could have a problem with the intersex, disorder of genital differentiation. So, it
Yes.
works out quite mathematically here, embryologically. So you don't have to think about it. When a question like this is asked, you work it out. Has to be there, nothing else. Yeah.
Yes.
Similarly, if you get a case of reflux or renal anomalies, developmental anomalies, you have to think of genital anomalies also that could coexist.
Okay.
You will be asked about them.
That is why the specialty is called genitourinary surgery.
Yes.
The university, it is still called a genitourinary examination, not called urology exam. Even though Dr. Rajshekhar tried to remove the genital away from it. Yeah, he tried to say urology.
Yeah.
Urinary surgery. You look at the exam paper, university, all that. So.
Okay, let's move on then. Priyanka, you will have to tell them to move on.
Yes.
Okay.
This is the video of the deroofing of the prostatic cyst.
Do you want to ask them something before the video? I mean, video they've captured, fair enough. But something more you want to know? Because this was the second surgery. Anything more about the first surgery?
Wasn't this the first operation?
No, this is the second.
Second.
First was the orchiectomy.
Oh, yes, oh, that. Okay, right, that way.
Freeze the video,
Okay.
Shubham.
Yes.
Let him answer that question, please. a patient comes to us at 19 with a history of orchiectomy done sometime in the teens or maybe a little earlier. What all information would we actively seek?
Orchidopexy was done, not orchidopexy.
Sorry?
Orchidopexy was done, sir.
Orchidopexy was done because he said orchidectomy.
No, sir, orchidopexy.
Orchidopexy. Okay, fine. At orchidopexy, supposing you're doing it in a child or in somebody who's 10 or 11 years old, is there anything you would do along with the orchidopexy? Dr. Prabhakar, welcome.
I was in line only.
Yeah, I know. I heard your voice. Good that your boys are presenting.
Thank you, sir. This is a very nice case.
See, whenever there is an undescended testis, our greatest suspicion and worry is about the presence of malignancy.
Malignancy.
Right?
Yes.
And we know that the longer the testis is in its foreign place, the risk of malignancy increases. So would you do a testicular biopsy at the time of orchidopexy?
Yes, sir.
Remember this.
Yes.
Especially if the testis shape is different, if it is soft, if you find any calcified areas or hard areas in the testis, a biopsy must be done. And if somebody comes with a history of having undergone orchidectomy, we should know what the
Biopsy.
histopathology was. Yeah. So please go on.
Yes, sir. So the cystic fluid was sent for the fluid analysis.
No, at endoscopy, what was the kind of fluid that you encountered?
Actually, it was done in outside the
It
hospital.
was done outside the hospital. Okay,
Yeah.
fine. Did they have any notes?
What idea? How can you answer that question? Supposing you're pushed to the wall and say what kind of fluid. There's a specific reason as to why Dr. Mohan asked you what was the nature of the fluid that came out. Can you take a guess? Can you hazard a guess in view of all this history that this fellow's had? What do you think would be the color of that fluid?
The color of the fluid indicates something about the etiology, sir. What is causing the fluid to get accumulated? It could be.
No, with that in view, that's why he's asked the question. What do you think is the likely color of this fluid?
Mostly, sir, it's clear and straw color, sir.
Okay, I'll put it to you this way. Situation number one, fluid is clear. Situation number two, the fluid is turbid, but it flows easily. Situation number three, the fluid is turbid and is very viscid, thick. And situation number four, it is yellowish or yellowish green.
So the clear fluid could be due to the secretion from the cyst epithelium, sir. Just the clear fluid, sir. In case of turbid, sir, long-standing fluid collection may result in stagnation and infection of the fluid, resulting.
Remember, Priyanku,
Yes, sir.
you have to answer this. Why are you letting
Yes, sir.
Shubham answer?
Yes, sir. So for the first case, as he has said, sir, it could be a cystic fluid. In the second scenario, sir, it could be due to presence of an infected cyst, which will lead to turbidity of the fluid. In the third scenario, sir,
Hang on there. What other meaning could this turbidity have? You say infection, okay, what else could it be?
What is the difference between last scenario and the second scenario?
See, maybe you've not seen this, but many people who got ejaculatory duct obstruction due to a prostatic cyst or cyst sitting on the ejaculatory duct opening, when you incise, you actually get turbid fluid because it is seminal fluid. It's free flowing turbid fluid, and that's one of the better indicators of fertility or prospect of fertility.
Yes, sir.
You get it? So turbidity doesn't mean infection.
Yes.
About the other two situations.
Sir, third situation, sir, it said viscid, sir. So viscous, so
No,
it could be,
yeah.
it could be from a spermatocele, sir. The,
Spermatocele there.
sir, could you please repeat the fourth scenario, sir?
The fourth scenario is where it is yellowish or green, very thick, and you have to scrape it off the floor of the cyst.
What is this yellowness in the body due to? What is that change called? Why is the color of the urine yellow?
Sir, seminal fluid, sir, on long-standing,
Hey, urine, why is it yellow? Answer that question.
urine, sir.
I will give you a hint to answer the previous question. That's all.
No, even otherwise, we must know why urine is yellow.
Sir, urobil,
Sorry?
urobilin, sir, content because of urobilin.
It's because of urobilinogen. Okay. So why is this fluid yellow then?
Sir,
We've not answered the third question yet. Answer the third, then we'll come to this.
sir, the cystic, it could be a cystic content having communication with the urethral lumen, sir.
No, why urethral lumen? There's no ureter involved in this.
He gave you a hint, no? You have to scrape it off. You have to scrape it off. Have you seen in hydrocele sometimes? You get the fluid like this, and then when you look inside, you know, there's all sort of crystalline stuff and yellowish stuff. It gets all adherent to the tunica. Haven't you seen in hydrocele?
Yes, sir.
What is that could do to? What is that called?
You heard the word insipissation.
Yes, sir.
So that is insipissation of fluid. Some fluid has been reabsorbed from the contents, and so these have now become thicker, more viscid, and they're adherent.
And adherent there, because of that color, the yellow xanthochrome pigment is. It's all xanthomatous changes, so it's yellow in color.
Yes.
And the last one, where it is yellowish or green, very thick, immediately clouds your vision. And relate this with his symptoms.
So presence of an infection, sir.
Yeah. He's already complained that he gets pain in the perineum.
Yes, sir. Yes.
Right?
So,
And you're getting this. Many times, or even often, when this is a chronic process, they might not have systemic features of infection. But what you get out of the cyst will be infected content.
Yes.
So we should know when we incise and look at what's coming out, what it's likely to be. Okay, let's move on.
Sir, coming to personal and family history, sir, patient is non-diabetic.
So you put up some report there.
Yes.
Let him comment on the report.
Okay. The cyst deroofing was done, and microscopic examination, sir, the appearance is yellow, and the value of the sugar.
Let Priyanku look at
Yes,
it
sir.
and tell us,
Yes.
is there anything worrisome? Nothing worrisome.
Would you like to query this report? Would you like to ask a question on this report, Priyanku, if you are answering?
Sir,
How was this fluid collected? How was this fluid collected?
yes,
It was collected during transurethral resection, isn't it?
yes, sir.
So you will have all the irrigant fluid, everything going inside. They may be
Was
like
it-
what they used. They must have used glycine.
I would like to know if it was collected by using by direct aspiration, sir.
Yeah, do you think they did?
Because it is put here during transurethral deroofing of cyst. Done. So when you incise into that cyst, all this fluid will come out, will mix with all the irrigant fluid.
Mix.
You
Yes.
don't know what is happening, whether these values are correct. So the best way, if this should have been aspirated before you did anything. So you
Before.
have an idea as to what could be the actual content. So transrectal aspiration would have been a
Yes.
better way to actually identify what are the origin and the contents of the fluid.
Okay, let's move on.
Yes, sir.
So the patient is non-diabetic, non-hypertensive, bowel habits normal, and patient is not addicted to any substance abuse. There is no any significant family history. Generally,
What family history, Priyanku, would you look for?
Sir, patient had a history of undescended testes, sir. So
Okay,
if there
fine.
is any similar kind of history. Yeah.
Undescended testes, what else could be there? That's where we go back to the question we were asking you. And Dr. Ganesh asked you, what are the associated urogenital anomalies? So somebody could have undescended testes, somebody could have a reflux, somebody could have something else. Okay,
Yes. Yes.
yeah, let's move on.
so on general examination, patient conscious, cooperative, well-oriented, Tanofsky score is 100%, temperature normal, pulse vital, blood pressure, right arm supine position 116/80, and there is no pallor, icterus, cyanosis, clubbing, and lymphadenopathy. On a genital examination, a normal meatal opening, normal glans, normal penile shaft, bilateral testis palpable in scrotum, and perianal sensation is normal. And so
I'm repeating this, Shubham and everybody else, please say both testes palpable in the scrotum.
Yes.
By definition, testis is a bilateral organ. It is wrong grammar and wrong usage. Both ureters, both kidneys, both testes, right? Okay. Now, it's not enough if you say they're palpable in the scrotum. Priyanka, what more do you want to know?
What was done for this testis?
Orchidopexy, sir. Consistency of the testis,
More
sir.
important than consistent.
Right.
size of the right
Test- Size, testicular sensations, sir.
That is more important, isn't it? You brought your testis down, you may have done
Yes,
something. So you want to know whether this testis is of a decent size.
Yes.
That's the first thing to know.
size of right testis is smaller than the left testis, but sensation is normal.
These days, we generally define it by volume. So make it a habit in your own institutions. Tell the sonologists, when they do the sonography, to give you the volume. And when you put it in history, you can say it has a lower volume than the other side or a higher volume than the other side. And if it has a higher volume, then you must say whether it is in the normal range or whether it's abnormally larger. Yeah, go on.
On systemic examination, per abdomen on inspection, normal centrally placed umbilicus, all quadrant moving equally with respiration. There is no scar, sinuses, dilated vein. On palpation, inspectory finding confirmed, abdomen soft, non-tender, no any lump palpable, and all the other system normal, sir. Sir, one thing I missed, that there is a scar mark present on the right
Inguinal region.
here.
Okay, that's all.
Sir, on digital rectal examination, the perianal sensation is normal, no visible external tag or hemorrhoid or fissure, anal tone normal, There is smooth, firm, non-tender, cystic swelling felt over the prostate. There is mucosa mobile over the swelling. No other induration felt. Returning finger, non-blood stain, and bulbocavernous reflex is present.
I want to ask you, Shubham,
Yes, sir.
what is this rectal mucosa, or what is this mucosa which is freely mobile?
So the rectal mucosa is not fixed to the line.
So when will it get fixed?
Any malignancy, sir.
No. Under what is the finding which will be associated with the mucosa which can't be moved?
Sir,
Yeah, Priyanku.
if the swelling is actually arising from the rectal mucosa, sir, not
We often say mucosa mobile. We should know this. If mobility is affected, there is usually induration there.
induced.
Okay, so if there is
Yes.
no induration, you must understand that the mucosa will be mobile unless there has been some procedure done on the rectum. And then, Priyanku, why has he said perianal sensation normal? And bulbocavernosus reflux present. Why is all
So
that?
to rule out the possibility of some any neurogenic disorder, sir. So he had also patient had lower unit tract symptoms, sir. So those symptoms could be associated and because of some kind of neurogenic conditions also, sir.
When will we suspect the neurological cause for lower urinary tract symptoms? We can't suspect it in everybody who's got LUTS, correct?
Yes, sir.
So when will we suspect a lower urinary tract cause? I mean, a neurologic cause for lower urinary tract symptoms?
Sir, young male, sir, who is unlikely to have prostatic pathology or he is not having any history of trauma or other kind of.
Can you give me the positive things and say, if this and this is present, then I will suspect?
Sir, legs, anal, sir, abnormality in the anal tone, sir. Absence of
Before you go to anal tone, are there any other signs of possible neurologic illness or neurologic disease or abnormal?
You might have to rephrase the question. He probably knows the answer, but I think he's not as good.
In a young 19-year-old male,
Yes.
what neurological conditions can present or produce lower urinary tract symptoms? Priyanku, a lot of work to
Yes.
do.
Yes.
Called neurogenic bladder. You're talking about reflex and all that, isn't it? So, which is the nerve segment which is involved? Which is the segments which are involved with that? Bulbocavernous reflex, perianal sensation. When is all this affected?
Yes.
Sort of spine.
L3 to S2, sir.
Hey, come on, think again. We sit on S4, we stand on, you remember that?
Yes, sir.
So if you're sitting on S4,
S4.
which is a segment that supplies the perineal and the perianal area. Which also incidentally supplies the bladder and the bladder outlet.
What do you say? Why is it so difficult to answer this question? Which nerve root are you testing? Man?
Yes, sir.
Which one? S1, 2, 3. Which one? You know the answer, I'm sure.
S1, sir. L5, S1.
No, man. Which is the nerve root they want to stimulate in this interstitial and neuromodulation and all that for the bladder? जाके पढ़ो यार तो बहुत ही हिंट्स दे दिया Carry on.
Yes.
Shall I proceed, sir?
Yeah, please.
So investigation, CBC within normal limits, sir. Serum creatinine 0.98 milligram per dl and blood urea 19.8. LFT within normal limit and serum electrolytes within normal limits, sir. On urine routine examination, sir.
Shubham,
Yes, sir.
I want you to remember, don't put CBC within normal limits.
Okay, sir.
It's important to know what is the WBC count, what is the lymphocyte count, the neutrophil count, and the other subtypes.
Okay, sir.
Okay, there might be something there which we will miss if you put it as CBC normal.
Okay, sir.
Supposing this patient had 20 monocytes, but the total count was, total WBC count was 8,000. Yes, supposing they did this in a patient like this, and they found that there were 20 monocytes present on that peripheral smear or on the stain preparation. When they counted on differential, they found 20% monocytes.
Due to, sir, any granulomatous reactions, chronic, the monocytes and macrophages are present, sir.
In peripheral blood, it's like 20% monocytes. And
Yes.
patient has come to you with urinary tract symptoms and backache.
So chronic inflammatory disease, sir. Any chronic inflammatory disease will result in
Not lymphocytosis. He's come to you with monocytosis, 20% monocytes. Hey guys, come on, somebody else help him out here. Nayan, Karnakar, final years.
Kind of viral infections.
Infections will always manifest with systemic symptoms, right? Fever, this. What is the most dangerous thing when you think of when there is monocytosis of this degree? When you're looking at a blood film preparation for a differential. 20% monocytes. Can it be some malignancy?
Yes, sir.
What malignancy? Which, incidentally, many times is picked up by urologists.
Monocytic leukemia.
No. In leukemia, all counts are elevated with predominance.
Yes.
Here, the total count is normal.
Okay.
8,000, but 20% monocytes. And maybe urine shows trace protein or 1+ protein.
Okay.
Go read up about this.
Yes.
Okay, because nearly 30% of patients with that particular disease present to the urologist.
Okay, sir.
Or to the nephrologist.
Or to the nephrologist, yeah.
Multiple myeloma, sir.
Yeah, what is so great about it? He's got back pain, he's got low urinary tract symptoms, he's got monocytosis. We have to think of multiple myeloma. Yeah, otherwise, we'll keep on doing all this transurethral resection, this circus, and we might lose the patient. He'll come 3 months later with weight loss. Okay, let's move on.
Sir, on urine routine examination, sir, there is presence of infection in the form of increased pus cell.
No. Don't make that conclusion.
Yes, sir.
Priyanku, just read out and tell us
Yes,
what you think is significant in this.
So appearance is turbid, sir.
Yeah, start with the
Significant finding in past cells 10 to 12 with presence of bacteria, sir. So associated urinary tract infection is present, sir.
Is there something missing?
with pyuria, sir.
No, there's something missing here. Oh, okay, they've given it differently. Fine. So you think he's got urinary tract infection?
Yes, sir.
Why doesn't he have fever?
What do you call this condition?
Sterile pyuria, sir.
Sterile. There is growth.
Growth is, sorry, sir. Growth is, yeah.
He's got bacteria. Is symptomatic or asymptomatic? He's got no fever, he's got no nothing. What's that bacteria called?
Asymptomatic
Yeah, good. Asymptomatic bacteria.
bacteria.
Let's move on.
Patient undergone, sir, Euroflow, sir.
So,
Let's forget the figures. Let's just look at the graph and tell us what you think. You can only look at the voided volume to see whether it is a valid Euroflow.
yes, sir.
Then, tell us what you think of the graph.
So it's a large voided volume with prolonged duration of void and mild.
Look at the graph.
Yes, it's not an absolutely normal graph. Shows features of mild equivocal range. The maximum flow. It's 17.9. So
Is this a normal shaped graph?
no, sir.
It's not a normal shape.
It's not a normal shape. The time
So-
to Qmax is more than
I
1/3
said
of the.
don't look at the time. Just look at the graph, the configuration of the graph,
Yes.
and then we can start looking at times.
Yes.
See, in times there can be several artifacts. We'll discuss this some other day when we discuss uroflowmetry.
Yes.
In the graph, you said it is not normal. So, what are the characteristics in this graph which make it not normal?
Sir, in the graph itself, we can observe that the peak flow rate, which is
Shape.
observed,
Shape.
shape.
See, Priyanku,
Yes, sir.
rates will come later. The graph is not normal because it is not bell shaped,
Not bells.
correct?
Yes, sir.
And from the graph, we find that the graph is flattened at the top,
Yes.
right? And that the voiding time appears to be prolonged.
Prolonged.
There is an afterflow, correct?
Yes, sir.
And there are no spikes to suggest that he has strained during
Strained.
voiding. And the stream is not interrupted because he is voided continuously.
Yes.
These are the things we can make out from a Euroflow graph.
Okay.
And then we can come to all those figures. Now you read out the figures and tell us what's normal, what's abnormal. At least tell
So
us what's
the-
abnormal.
Void duration, sir, it's prolonged, sir.
Is there a reason why this void duration is prolonged?
The time to maximum.
What are the normal conditions under which the duration might be prolonged? Nothing wrong with the bladder, but the duration is prolonged.
Large voided volume, sir.
An over-distended bladder, large voided volume. So look,
How much is it? 600, huh?
623.
623.
23. So, he's having a competition with his other fellow. Huh?
The first thing I'd like to tell you about all this is, if the voided volume is not normal, it is between 200 and 350 ml, take everything else with a pinch of salt. Just look to see whether there is straining pattern or whether the flow is interrupted. Because
Yes.
all other figures will change. You would all have experienced it when your bladder is full, you've been in theatre for 8 hours and you rush to the bathroom after that, you take a long time to pass your out. Right?
Yes.
And the flow may not be good. Certainly not initially.
So when you eyeball a figure like this or a curve like this, eyeballing you say, okay, it looks all right. It's just not absolutely the shape that is described, but you know, you look at other parameters as we said, you will pass it off. All right. Say that is probably not obstructed.
Okay, let's move on. Dr. Prabhakar says it's an interesting case, so let's see what else is there that we can discuss.
The patient who had undergone widening cyst urethrogram, sir.
If possible, take individual frames by cropping the rest out. Okay, so that we can focus better on the abnormalities. So describe, Priyanku. What does this show? You forget the lower two films, doesn't matter. Just the top two films.
Yes, sir. So in the first film, sir, we have anterior urethograms.
You know what was done for him. You know what was done for him. You've seen the endoscopic pictures, and now you're seeing the RGU or ascending urethrogram, whatever you want to call it. Dr. Mohan wants you to describe it. What are you seeing there?
The anterior urethra appears to be normal in the first film, sir.
Okay. Then you must look very carefully at it, okay? Look very
The
carefully.
posterior.
Rather than call it anterior urethra, describe it in segments. The penile urethra, the pinobulbar segment, the bulbar urethra, and then the bulbomembranous junction. In each of these, see whether there is, whether everything is normal or whether there is something which is not normal.
Penile urethra appears to be normal. The pinobulbar junction is also normal. The bulbar part of the urethra is normally distended. In the bulbomembranous junction, there appears to be slight abnormality.
That the abnormality that you're seeing, Priyanku, is not at the bulbomembranous junction.
Yes.
It's almost at the level of the pubic symphysis. Okay, so these
Yes,
landmarks you must be familiar with. You must be clear. That's not the bulbomembranous junction.
Is it above the pelvic floor or below the pelvic floor? That abnormality. Is it below the pelvic floor or above?
Above the pelvic floor.
How do you know that? You're right, but how do you know that? You're taking a guess or? Where is the distal sphincter? Anatomically, the surface marking of the distal sphincter. You don't know? So something more to find.
Distal end of the.
No, all surface marking. That means surface marking we are taught in anatomy, no?
Yes, sir.
There, where exactly? If you draw a line from this point to this point, this is where it will be. This is where will be the sphincter. So what's the usual when we say at what level is it? you draw a line through the midpoint of both operator foramina, anything above that will be in the true pelvis, above the pelvic floor. All right. Some people also say you divide the symphysis pubis into the
Yes.
junction of the lower third with the upper 2/3, you will get the sphincter. So now if you draw, although this is not a absolutely straight AP picture, there is some semblance and you can have some idea as to what the effect is and where is it actually. You have to titrate this RGU, as I said, with the picture that was shown to you. Then you will be able to figure out as to how, why.
Midpoint of the operator foramen, sir.
Huh?
No, you forget that. Now we are telling you this is above the pelvic floor.
Yes.
So what is at what level in the urethra? What urethral segment are you finding the
Prostatic
abnormality?
urethra, sir. It will be in the prostatic urethra, sir.
We know it is the prostatic urethra. Anything else there which tells you it is the prostatic urethra? Is there any other finding on this RGU which tells you it's a prostatic urethra? Is there a filling defect there?
Sir,
Look carefully.
it's above the level of the verumontanum, sir.
That is the verumontanum, not that is the verumontanum. What you're seeing there is the verumontanum, all right?
That's where this stream will split into two
Yes.
to go on either side and then rejoin to enter the bladder through the bladder neck. That's how we identify the prostatic urethra.
How,
Yes.
when they do this RGU, remember this patient has had a procedure on the prostatic urethra. They have deroofed something, isn't it? So there is a cavity now there.
Yes.
So it's like the density of the contrast in the middle and the density of the contrast around it. So you
Yes.
see, stream which is going like a jet, going into this the center one, which is fanning out, and then it is also going into the bladder, which has got some urine in it, and that's taking a globular shape. So you have two densities there because you have two structures. And if this were in a true lateral picture, you would have seen that this is going posterior, this fan-shaped contrast going posterior, and the bladder is anterior. All right? I mean, just try to titrate these things. You'll be able to figure that out. I think they are showing that lateral here in the bottom left. Yes.
Okay, any other films?
No, sir.
No.
Actually, and the micturating voiding, for first film is the ascending urethrogram.
Correct.
And right is the micturating cyst urethrogram.
Maturity. Okay.
You can see two things. One
Yes.
and the other one, the bladder. The superimposed.
Blur.
And down left is the lateral view with micturating cystourethrogram. You can see bladder separately and the cyst separately with a, in between there is a
Contrast in it. Yeah.
yeah, contrast. And the last one is the post-void. Bladder is completely empty,
This
but the
is
cyst
filled.
still
Cyst
not
is
empty.
filled.
Yeah.
That's right. So an oblique view would probably have given us a good idea of where the contrast was going and what was filling up first. And this is a good one. Actually, if you see the second film in the top row, you can actually see that that particular contrast-filled cavity is beginning from below the pubic symphysis. You know, below the lower border of the pubic symphysis. So that must be the cyst.
Yes.
Okay, let's move on.
Sir, can we say that since the cyst is overlapping the bladder, sir, it mimics pear-shaped bladders from this shape of this bladder?
Say,
The shape that is shown
don't
in this
overinterpret, Priyanku. Okay. We
Yes.
know because Dr. Prabhakar has told us what it is now. He was there when this was done and he has seen it.
Yes, sir.
All that we can say is there seem to be
Okay,
two
sir.
cavities filled with contrast. The lower cavity is more opacified than the globular upper cavity, right? So whether it is a double
Yes.
contour bladder or whether it is a bladder with something else, we don't know.
Okay, sir. Yes, sir.
Yeah.
Sir, after the patient, we did a cystoscopy and the video.
Actually, this cystoscopy also is done outside, I think.
Yes, sir.
When he had this problem again, he went back to the same surgeon,
Right.
and this cystoscopy was done. This is the cyst inside. You can see the cyst.
Right. And nice findings in the bladder.
That is the opening. This is the and that is the bladder entry.
Yeah. Right.
When he explained his symptoms on the basis of all this now, let's get down to the problem that he had. Getting late.
Priyanku, can you explain his symptoms on the basis of these findings?
Sir, congestion is present in
No,
the
you
bladder.
forget the bladder.
Wait.
On the basis of what you found so far, all the findings put together, can you explain his symptoms of hesitancy, poor stream, urgency, and frequency?
So right from the history till current findings, sir.
Yeah, no, now you're seeing
Sir.
what the findings are. He's got a large cavity there, and
Yes,
they
sir.
have a little difficulty entering the bladder because they have to go up and enter the bladder. Does this explain why
Yes,
he
sir.
has got hesitancy,
Yes.
poor stream?
Yes, sir. Sir, patient has got a recurrent large prostatic cyst, sir, which is putting an obstruction to the bladder outlet. This obstruction is creating, giving rise to the voiding, to the lower tract symptoms which he has presented. And again, it is the same cyst which can cause an obstruction to the at the level of the prostatic urethra to the opening of the ejaculatory ducts. So, which is giving rise to the ejaculation and painful attempts at ejaculation. Also,
Manish, Manish,
Yes, sir.
can we continue this for the genital part next week? Let these guys also read up with respect to evaluation of ejaculation and prostatic pathology.
Absolutely, yes, sir.
Dr. Ganesh, is it okay?
Yeah, it's fine, sir.
Dr. Prabhakar?
Yes, sir. Fine, sir.
So we will take up the genital symptoms and all these findings. We
Yeah.
can leave out the rest of the presentation. We will
Yes.
begin with ejaculation
Yeah.
and then look at all this.
The urgency and urgent contents and poor flow, because it doesn't have a poor flow.
Right. Priyanku and everybody else,
yes, sir.
please also read up imaging for the genital tract, which is important. Okay,
Yes.
an RGU MCU will not give you the information you seek. So next week we will discuss all that. Okay.